All right, well, good evening, everyone. It's really exciting to be with you tonight. This is our last session in an 8-week course on Introduction to Palliative Care in Limited Resource Settings. And we're really so grateful that you're with us, that you're on time, that you've joined for the sessions, and we're really looking forward to the training today. I see some people have introduced themselves in the chat. It's great. Welcome to Mateboho from Sepinare HC. Great to see you, Annette and Joan. Wonderful to have you calling in from South Africa. We have someone from Mote Bang Hospital. It's great to see you. From the social department, a nurse midwife, lots of people. Keep them coming. Sister Tebello, of course, knows how to pronounce your names much better than I do, but my name is Erin, and I am a Canadian palliative care nurse living in Kenya and have been working with Palchase for the last year or so. And I'm really excited to be able to help facilitate the session for today. The topic that we're going to be covering is neglected cancer care needs of patients living in Lesotho. And we know the current context in Lesotho, where many patients have very limited access to cancer treatment and care. And we're going to talk a little bit more about that. Tebello will be leading us through the session today. Of course, she doesn't really need an introduction, but Tebello has been leading this training course online, and we're really grateful for her enthusiasm and the example that she shows each one of us each week as we come to the training. So she is representing Starlight Oasis of Hope Hospice, a registered charity in the UK, doing work to promote and advocate for palliative care in Lesotho endlessly. I feel like I should add to the end of the introduction, without fail. As Dr. Hassan has mentioned, I'm not sure she sleeps very much, but anyways, we all need to sleep, Tebello. You need to sleep. And then after Tebello teaches our session, we will be having clinicians from Lesotho bring a case related to cancer care, and that will be Dr. Hassan as well as Dr. Tonny, and we're really grateful that they're with us today. Depending on how things go, this is our last session, so we did want to do some follow-ups. We may stay in large group discussions. I will also be keeping time on Sister Tebello in a very respectful way to make sure that we do have time for discussion as well. We may not have time for the small groups, but we'll let you guys know as we're going through. So thanks, everyone. Please do put your video on if you're able to. Stay muted just so we can hear the teaching for today. And if you would like to make a comment, you can raise your hand. It's really great to have you. All of our faculty are with us. As many that were able to join are with us today. And if you would like to reach out to them, they do have a hashtag in front of their name. So over to you, Tebello, and welcome for the session.
Thank you very much, Erin. I don't know where the tears are coming from, but somehow there's something that is welling from the depth of my heart. I think it's just to acknowledge how the divine powers can use his own people to coordinate whatever the divine has really agreed and mandated to happen over this other side of the kingdom. I'm saying this because I just feel very, very much humbled that we have come to this stage. And these are the things that one has written in the vision book since 2017 or even before. And to see most of these things happening as you are ticking them one by one, and you know you have not done much, but it's just out of the compassion, the commitment, the love, and really dedication from many of us here and not even here on this call. But I just want to thank all of you. Thank Major for having been persistent, supporting me all those years when nobody believed that this vision would come to pass. She was really walking side, holding my hand, encouraging. And I want to thank each one of you. Erin, no words can describe the level of commitment you have to the people of Lesotho. And I just want to thank you and your dear family, because some of the sacrifices have been just too much and too stretchy, but you have managed to do it for us. And I thank all our partners, our Palchase family at large. Thank you, Meruth and Palliative Care Works. Thank you. You know, there's a saying that you are only 4 steps or 4 people away from the people that are meant to bring a breakthrough to whatever you dream for yourself or for your profession or for anything, but whatever you desire, you are only 4 people away. And I've seen that because it's been a collection of people that have been committed in doing so much to support, even if it's just a network, 1 email, 1 SMS, but just that little call, it has brought this training to Lesotho for free. When I see it is for free, and people have committed their family time when they should be around the tables with their loved ones, checking how everyone has been throughout their day, I just I'm left to say, honestly, I just want to thank each one of you. Thank our friends here. We have got a Dr. Ian, we have got a Dr. Annette. They are so committed as well in supporting the palliative care growth and development in Lesotho. The depth of the commitment from each one of us here is amazing. And maybe I should start the training, because it's as if I will never enter. Thank you. We also have in our groups here, our participants who believed in this training. So many got invitations. So many even signed up, but they didn't believe in it in the end. They didn't feel like they should be part of it. But here we are, we have journeyed, and we believe the knowledge exchanged will benefit the Lesotho on the ground. And it will inspire us to remain advocate in our own little ways, in many ways that the voice within us will speak through us. We are seeing time and again how people have been humiliated with their dignity put on the line, with their pictures on the Facebook all the time, simply because they just want to show the proof that they are desperate for support, because they've got this growth and the cancer that they don't know how to manage. They don't have painkillers, they don't have dressings, they don't have 4,000 Rand to pay for the scan and everything else. But we can be advocating wherever we are. Now, Dr. Hassan, thank you, and Dr. Tonny, for whatever hard work you are doing to make a difference in whatever way you do. We want to thank as well Dr. Mpuse, our only female oncologist for that matter in our kingdom. She's not here, she's too busy trying to build the systems around oncology care. So that means to say she has got a limited time to join us. But I just want to say all those baby steps that we are all doing collectively, I hope and believe that with persistence and consistency, we will come to where we need to be. But the commitment for all of us, I think it deserves a great, great thanks. Thank you. Erin, we can start, you know. Thank you.
Sounds good. Would you like me to share my screen?
Please.
Okay.
Are you okay, or should I share?
No, it's okay. Sorry.
I might find it. Are you okay?
Yeah.
Okay. And time me, please. I think I've already eaten so many minutes.
That's okay. We will have the content shared as a PDF like we normally do. So even if there are a few slides you want to skip over, just let me know.
Thank you. Thank you very, very much. And yes, it's just about the neglected cancer care needs, which we know they struggle from the point of being in pain, being challenged by symptoms, being challenged from social aspects, spiritual aspect, and as well as socially. We know all these things, and psychologically, they are overwhelmed by the diagnosis. And we know how much these people, most of them, lose income over all these disease journeys. So next slide, please, Erin. And the next one, just to acknowledge that all these slides, they have been the brainchild of the efforts between Dr. Megan Doherty as well as Erin. And we have been adapting here and there just to personalize our presentations, but they have put all the hard work in the background. Thank you. And the objectives is just all to see how best the public services and charitable organization can still work together in the limited resource setting to ensure that the beneficiaries receive the best care possible within the limited means that we live in. And to ensure that these patients, they don't really suffer more than they are already suffering in terms of trying to find this expensive money to purchase the investigations, whether it's scans or even cytology tests. These things are very, very challenging for individual families. And we just also try to see how best we can all work together as multi-professionals and ensure that the referral systems are really well managed and seamless. Thank you. Next one. Kingdom of Lesotho being where we are, we know we have got the national challenges with a high symptom burden of chronic conditions, including non-communicable diseases, not only cancer. We have got a high rise in figures in terms of the kidney disease. I don't know if we have noticed that of late, there are so many people with kidney disease, and there are so many medications are on the market that have not been tested, that our people are drinking just in the name of all remedy for all diseases. So all these things are coming as a challenge, and the high disease prevalence in terms of HIV and AIDS with all the medications, the livers and the kidneys are now chronically challenged, and the complications around other ailments like hypertension and diabetes. We just needed to all up our games just to see what we can do within those limited resources to do our best. But then we are challenged as well by not having, the active cancer registry. We are only starting that journey since Dr. Mputwe has been with his Sankatana. That journey has kicked off. But before then, we had no clue how many cancer patients that we had, because we would only have those numbers that are referred to South Africa, of which many of them don't really get captured because they don't end up going because they don't have money for all these expensive tests that will confirm their diagnosis or even allow them to proceed to the next phase. And we needed to really embrace the need for evidence-based practice through doing more research so that we can support the arguments that we claim. Regionally, we are part of SADC, 16 member states, of which out of them, it's only Lesotho that has not got the established palliative care services for their people. So we needed to work together to bring that change. Like I've always been saying, our children might be too young to bring about change. Our parents might not even be still alive to bring about the change, or too old. But then it is our season and time in this generation. It is us who need to take a firm stand and then really move away from looking what is in there for me before we can make a decision. But what is it in there for all of us? Because who knows who needed these services we are talking about. Internationally, we are committed as Starlight to really go about communicating as we do, even in this evidence that we have here, to collaborate and partner with everybody and every organization that is of like-mindedness, that we can move along. And then thankfully, we have been having the sisters and the brothers across the world that understand the situation in Lesotho, and hence why this level of partnership. Next slide, please. Cancer journey in Lesotho, as we know, can be very much unpredictable. You can be back in Simongong, where I come from. you just see a lump and you think somebody has bewitched you. Take your time before going to the clinic. Even to the clinic, if you are referred to Maseru or to Roma Hospital, you might not even have money to really go for those tests. If you happen to have money to go there, then you are told about the tests that need you to go back home and sell your sheep or your cow. In the end, you don't even end up going to South Africa. So even if people are captured and they are diagnosed, challenges are there most times diagnosed very late, because we still needed to really strengthen our, our screening, early detection, so that the things are identified at the very early stages to really maximize the outcomes. And again, sometimes patients were even going to India, and these are coming at a very personal and national expenses. So we all needed to do something to really make a difference, even if it means just symptom management, to make a difference in the lives of individuals and their families. Next slide, please. I think all throughout our series, we've been talking about total pain, and there's no way we can manage the total pain without including other professionals. So if there's any two things we can remember, is the multidisciplinary approach and the total pain or total care model. Because at the end of the day, we know that within the dimensions that we have as human beings, we have got so much that we need to take care of for these patients and their families. In as much as in the previous sessions, we've been talking about taking care of ourselves, because we'll be taking so much from them as we deal with them day in and out. That is why the social workers are really the people of this season for me, because without them being active, being involved, we can provide the psychological care that the patient don't give up hope, they don't get depressed. We can really introduce the medications to manage their symptom challenges. But then where are the chaplains? Where are the social workers? How do we incorporate them? Because they are part of the journey. They are part of that team that needs to make a difference. So those are the main challenges for us in Lesotho as we look at to the future of how best we can take care of our patients and their loved ones. Next slide, please. It's all about taking care of each other, being everyone's brother. If I look after yourself, then you can take care of me. We just need to exchange that inner thing that is a wiring between humanity. We are born to take care of each other. Even the animals, if you look at it, simple cats as they are playing around in the house, you will see there's that level of love and care. Why can't we do the same? It's not just about those people that are queuing outside, really hungry and cold, waiting for the little van to take them to Bloemfontein when they haven't even had something to eat. Coming away from really far, hard to reach places just to be transferred to Bloemfontein. How do we make that a difference? How can we really contribute in our own different ways? Honestly, it is just all of us together to make a difference in our own individual ways. Just because for me, as I've been saying, you know the story. I am just the only child of my parents. But what brought me into this love that goes beyond my own family setting is to realize that time is something that we need to value, is so precious. Because within the moment that my own were taken away, within a split second, I realized that we can maximize so much within the time from when the patients show symptoms, when the patients are given diagnosis, to the point whereby even the treatment might not be the best option for them, but there's so much that can be done within that time. Palliative care is all that we need, because we have only got one chance to make things right in palliative care. Next slide, please. I think for sustainability of the programs in Lesotho, it's all about ensuring that we address the morphine access and availability. We also have to embrace the partnerships, because as charitable organizations, one of the challenges will be sustainability. But if there is a buy-in from our government through our ministry, which there's so much to, I should say, because they really embrace any idea that brings about closure to the care gaps that exist. They embraced us. That is why we have got a memorandum of understandings with them. But it needs to move a little bit further to the financial commitment. How do we get assistance so that all the ideas we have for Basotho, all the plans that we have to put in place to really address the care needs, they are not lingering because we are trying to raise funds from our family pockets, from our friends, from our networks, and it takes time. It's not just suddenly that you can get help to bring about change. People need to test and see if you are really committed to what you say and preach about. Now, again, it's integrating this palliative care in the existing programs, in our cancer care, in our diabetic care, in our dementia care, in our mental health, in every dimension that we really provide care for. But we need to ensure that there's a palliative care element. It doesn't have to be something we worry about as if it's something new or something that will stand alone and need so much money. It's just to integrate it and see how best forward we can be. And we thank the palliative care family and the rest of the ICPCN team, because they are really working to partner with us time and again so that we can really work together to really unfold the possibilities of making things achievable within the limited resources we have. And again, we need palliative care teams within our districts, hospitals. Are you in a decision-making capacity? Is it you who will be around the board or even in the boardroom when the decisions are made, whether this idea that is pursued by Starlight, that they need to have palliative care teams in the district hospitals in order to support and mentor them so that multidisciplinary teams becomes effective to support patients? Are you one of them that will stand against it, thinking it's Tebello's idea? It's not my idea. This is an international obligation which each and every state has signed for, that palliative care is a human right. So we just need to work together to make things possible in wherever capacity we operate from. To close the knowledge gap, we are already doing it with our colleagues as we are now, and we are really grateful that we have decided to be part of this journey. And again, just to continue collaborating with other regional institutions like our University of Cape Town, which is very much willing with their teams. And again, globally, other universities that can partner and really work with us. The journey does not really happen overnight. It's a matter of being patient and persistent. We are really, we have kick-started that process, and we will continue to do so, being the bridge between whatever needs to happen on the ground, so that we have this program within our undergraduate programs in the health institutions. So that is all about going digital as well, embracing the change that is happening on the ground. We cannot just wait for the paper to come from Smonkong with a referral note, which even if that patient becomes unwell and loses the bag on the taxi on the bus, then we won't have the information. That little bookana that they take to Bloemfontein, if they lose it because they've been so unwell, they're feeling so sick, and the bookana is nowhere to be found, then we don't have information from our Bloemfontein colleagues. No, we needed to embrace the digital time. And thankfully, yesterday, I noticed that the big funding from our American side, the team that has been supporting Lesotho in many different ways, has really injected another Compact 2 funding. I think it's over 322 million US dollars. And one of the big chunk goes into healthcare systems. And I believe for those that are in the decision-making power can really progress at that area very swiftly. Hence why, as Starlight, we felt we need to do our own little bit. Hence why we have developed the digital app that will be launched whenever the systems are all ready, so that we can enable each one of you, the healthcare professionals, the social workers, the families, the patients themselves, they can refer themselves to us to highlight their needs. And then how do we advocate and to really make our own administration to be aware that within the national health budget, there has to be the palliative care budget, because as long as it is integrated with all the other operations, it is very difficult for people to really use it for that purpose, because it's a new program. And it's as if, why should we bother about the new program when there are so many that we need to fulfill, and that we have been doing them and the money is running out. So we need voices that will make the decision makers, policy makers understand the need. The next slide, please. In terms of morphine, I think I like this acronym for morphine. It is from the Treat the Pain program from American Pain Society, because before we can see any empowerment of any nature or transformation of any anticipation, we got to change the mindset. We got to organize the stakeholders and get everybody on board, including the cancer survivors, including the patients groups, just to know what they need so that we can address their needs. But most of them, they are so much that we can't even miss them. We know people are suffering because of inadequate pain management. So we need to do something about that. What about the law and the regulations? Those are the things that we need to tackle with the competent authorities within our nation, so that they deal with the international regulatory bodies, so that we get adequate morphine. Countries' pro forma is increased, so that we don't talk about paracetamol, even when somebody is expressing their pain is 8/10, over 24 hours, they are to do more, revisit our guidelines, revisit our policy to ensure the safety and everything else. So just move to the next slide. They will catch up on the information we're gonna send at the end. Advocacy is all about what we are anticipating to bring about the desired change for the benefit of every Mosotho. Those that have got their knees wobbling, weak, their voices are trembling, their bodies are shaking. The pain is at the core of their being. They just have got no clue what to look for into the future, even for just the next day, because they are in so much distress with pain, no food to eat, lost jobs, and they just need all that support. And how can we do? It's just through advocacy, communicating, liaising and networking. Hello, Erin. Are you there?
Yeah, next slide. Sorry, I think my internet was slow. Yeah.
Was slow. Okay. Dr. Zipiali, who has been really spearheading the much of the change within the environment of Kenya, has been saying without empathy and compassion, you will be doing advocacy for nothing. Simply because if you advocate today, because of other motives, without having the necessary compassion and empathy for the people, maybe just advocating for what is in there for me, you will of, I think, because it is the Even for the children, they can't play. They feel already vulnerable. They can't enjoy the other age groups. They can't go to school. They can't do anything. And at the end of the day, they feel so much vulnerable already. What can we do? It's just about speaking for them, speaking on their behalf. They don't have energy to go on the radios. They don't have the energy to walk to the parliament to advocate, or even to the authorities. So we just need to do our best to advocate in our little ways. Next slide, please. Managing change. It's all about adhering to the World Health Organization public health strategy, which is all about ensuring that there's a policy. We have got up-to-date policies. We align them with the national and international calls for palliative care to be part of all the care we provide, access to medication, and ensure there's adequate awareness and education for the people to be empowered, whether it is healthcare professionals or family caregivers. We just need to make sure that the knowledge is disseminated and we are on the go to support the care programs. Again, please, Erin. Yeah, it's all about ensuring that we have got all these dimensions. That they are innovative care for chronic conditions framework, ICCC. So it is all about the micro level. How do we empower communities, patients and their families, and keep them informed and supporting them accordingly? How do we now move to the meso level, where we are talking about the healthcare professionals and the healthcare providers being their organizations, to ensure that they have got those necessary tools that will enable them to provide care and support them accordingly, and ensure whether it is around moving availability, whether it is about ensuring clinical social workers are integrated into the healthcare systems, or everything else. We just need to address all these issues. Next slide, please. Then I think I just want to say, in all that we have achieved over these weeks, we will remain connected. Erin brought up an invitation earlier and said she would like to hear, indeed, we want to hear the feedback from you as to how we can stay connected and really move forward. What suggestions do you have in mind for the sustainability of the program, so that it doesn't come like anything that it can come and go and die down, but it's so that we maintain momentum. It means momentum is when the opportunity comes and it's aligned with the necessary skills and tools. So we will keep the WhatsApp groups open. We will also continue to ensure that we have got WhatsApp groups that connect people within their specific district. We have seen so much challenges of patients within certain districts, which if we have that case dropped in that district WhatsApp group, it is easier for the social worker to come on board and say what is their part, then the pharmacists on board, and the nurses and the doctors. So that will be easier for all of us to ensure that even before the policies change on a major scale nationally, but we can do something within our means and ensure that we keep the website up to date with the information. And also, Palchase has got so many webinars. Even if you haven't been part of them, visit their website, visit so much wealth of information, even videos, and ensure that we have got all this information. Najojo has got a website. We can really get a wealth of information from different platforms, even throughout the links we have been sharing, the WhatsApp groups, other international groups that offer trainings for free, our mother body, our umbrella body, APCA. You can get so much wealth of information for free. just register and then be connected always. Now, it's just to continue, as I mentioned, about the palliative, a public health strategy for palliative care and forming the steering groups to move forward, including the representation from patients, families, and survivors. The next slide, please. This is an invitation, I think, coming to the end of this session, which it is just only a break for us to re-energize and strategize for the journey ahead, because the journey is still long, but it's just to continue the advocacy bit, which we realized as Starlight, we have been taking on board to make things moving, but advocacy can be best done if it is part of the National Association. Education and training to ensure that we partner with everybody, including to really use the Project ECHO as the leverage to get through to people, to really give people the information they need and support them, and mentorship through our partners on board here that are committed to support us into that next phase. And also our academia to ensure that we support them, and curriculum can be reviewed with the support of our other professionals from other parts of the world, as I mentioned, the other university earlier, and ensure that palliative care is also embedded in each and every district health care facility. So it is all about seeing what do we need as a nation. We need to revisit all that we have, including the documents that ICPCN did, a lot of wealth of information for the children, but we need to same for the adults. We don't have them. But again, where are the advanced care planning? Where are the decisions about when somebody doesn't want to really go further with any acute treatment if they feel the quality of life is just needs just comfort care and nothing really aggressive. So we need to do all those treatment. We have mentioned about the medication, essential medication list and morphine being specific, that we need to ensure that those things are really addressed, and the research and innovation. The next slide, please. Each one of us is indeed a bridge that really can convey so much to give access to the patients and their families, really close the care gap, really address their total pain dimensions, and ensure that we support each other, that we can provide so much wealth of information between ourselves as healthcare professionals and debriefing sessions so that we don't burn out. We have had Harriet and Christina as they were really going through how we can take care of ourselves, our psychological elements and physical elements, just to ensure that we are energized so that we can support the others. So we all need to team up and ensure that we move on together. So that clip was shared in our WhatsApp group. I hope you have managed to listen to it. Next slide, please, Erin. What time is it? I think I've gone over my time, I think. This is the statement from this gentleman who was one of our kind, and he's still very, very creative and innovative. I believe he taps into so much wealth of information from the divine. This gentleman was studying medicine. He dropped halfway because he felt like the curriculum is just below his mental capacity. Then he moved on to do biochemistry. Still the same, he didn't stay there. Instead, he created his own curriculum. And all this speaks so much to us as humanity. He says we just need to move from looking into what is in there for me, being egocentric, always about me, but move and grow into looking what is happening within my community, ethnocentric. But even that is still a level lower. We need to move whereby we think about others, humanity at large, world-centric, and even our environment at a cosmocentric level. We just need to really embrace the personal growth, the personal development, and really know and understand that when we need help, we want others to give us help. So when we are in the position of power, influence, and impact, it is our time to make a difference in that time and moment, because you might just be in that position for such a time as this, just to make that simple authorization, simple signature to approve something to be done for the benefit of everybody who might even be you in the future. So he said to create societies that offer the best possible life to the most number of people. That is Kennedy Wilber. So the next slide, please.
Tebello,
if you
can wrap up in the next minute or so.
Thank you very much. I think it's just to thank all the commitment from our batch 1 as well as batch 2, everyone that have committed their time. We are just saying you have done it. The awareness for the need to have a palliative care as one of the skills and the knowledge base, you embraced it and you make a decision. That desire brought about committing your time and signing up for this program. Now the knowledge base is established with all the appreciation from all our colleagues and faculty members from across the 12 countries, of which some of them, the time is not so much convenient for them, but they've been committing. Now, we are able to move forward. The decision is yours. The choice is yours. Whether you want to take this knowledge to the next level, to influence your team, to influence the change within where you operate and practice, to really partner with Starlight and the National Association that we are to register when we get to Lesotho, to make and strive for change. Then we can continue reinforcing that. Erin has said it. We will continue with the programs in the coming future. We just need to strategize. We have got our seniors here, our mentors on board who are committed in the mentorship. And therefore, we can just bring about the change together. The next one's, Erin, probably is the last one. Continue, the next one. Yeah, it's all about, this one, please. And I think this one is just to say, all of us, each one of us, there's the purpose and the need why we are still part of, or those that are on this side of the grass, who are still consuming the oxygen that is given freely and without charge. There's a reason why our hearts are still beating. There's a reason why our faculties are still working. There's a reason why we are in those offices and sitting in those desks. We just need to really find what is it that you can do and really influence in this time and space for the benefit of everybody, not just what comes to us. The next one, and I think it's done, Erin, and I thank you. Do all the good you can, by all the means you can, in all the ways you can, in all the places you can, at all the times you can, to all the people you can, as long as you ever can. It's not about whether people are rich, knowledgeable, beautiful, come from good backgrounds. It's all about humanity. That is why PALCHASE, that is why Palliative Care works, that is why Project ECHO, that is why APCA, that is why everybody is on board, sacrificing their time. It is an investment into this moment in time. These divine investments, they don't come easy. They come because people are committed and they feel the need to take part. Let's embrace this knowledge, my colleagues and my own colleagues in Lesotho. This is an opportunity of a lifetime to utilize this knowledge, not just to shelve the knowledge away, but to apply it and make a difference. That is you. You can make a difference. You can bring the peace to the family and patients. You can bring and revive their hope. You can just give them love, even if it's just by listening and be quiet and exercise silence when they are really crying and tearful. This is the vision that we were given. And this vision came through the eyes in the spirit. It was communicated through conversation in one of the offices in 2018, I mean. This vision, as it was communicated to Medinel Lerotori, I hope she's with us. Medina Rotori is a professional architect with a heart for the nation. When she heard my speech when I was presenting 2018 at the first national conference about cancer in Lesotho, she really wanted to hear more. Why am I inspired to say and do what I'm doing? When I'm in UK, when it is so strange that somebody can be so burning with desire to help, being so far away when there are other professionals. In Lesotho, I went to her office, she created time. I communicated the vision. She says, my contribution would be, I will design the home for Starlight. Let me know what do you want in it. I just spoke. She just documented. And what she brought to pass is what I saw in spirit. And I'm grateful. I want to honor God because without him connecting hearts to hearts, minds to minds, there's nothing that can move. So let us just continue to do our part in our little way, but with a great heart. Not about what do I gain out of this, but is about what that little child, what can I do for that little child, that adolescent, that man and woman, that elderly with dementia, what can I do to make a difference so that their total pain can be addressed? Thank you, Erin. I need to submit now.
I am in the most respectful way asking you to end your teaching for today. Tebello, we are very grateful for what you teach us. And the participants, I'd like to open it up now for about 10 minutes or 5 or 10 minutes of discussion related to advocacy and even just identifying what you feel like are some of the neglected needs of your patients. There has been a comment in the chat saying, how can we accommodate the village health caregivers? I think this is a really good question. How do we include people that take the burden of a lot of the caregiving, yet may have very limited access to education? How do we support them? How do we include them? Dr. Tonny, do you want to comment on village health caregivers? I know you work in the community.
Yeah, hi. Hi, good evening, everyone, and good evening, good afternoon to those who are, depends where you are, you know, and good morning. Yeah, I think to share with other people, because we work indeed in the community and we see patients in the community. The village caregivers, the village health workers, they have a very big place in our care for the patients. They are the one they actually, because they are in the same area, they work together with the people. They know exactly where they need. In some instances, you find the patient doesn't even have someone to fetch water and they give it to this person. Sometimes it becomes even hard for the patient to use the toilet, particularly if the toilet is outside. The caregiver can actually be the person to be part and parcel of palliative care. So we have a whole range of village healthcare volunteers in our community that are actually doing a wonderful thing, wonderful work. And that is the making sure that the patient, because you find most of them, they know what are these, because in the evening they are with them, they know what they need. Rather than if you are traveling from your home, from a hospital, whatever, go there. But these people are living with them in the same vicinity. So they found accommodation, particularly if you find a family whereby the patient is more like alone. And some of them, they actually, you find there are no one who's helping them. And the caregiver, the village health care workers, these are the people that they found themselves. They are very useful actually to our patients. Most of them in the community, they are very, very useful.
And do you find,
even though, even though I would also say they also need help. You know, where they really bear a lot of burden, that they also need the help, because what they see and what they do, some of them, it's quite devastating. We get a lot of different testimonies that are quite shocking when they explain what they see and what they do. So they need to help themselves as a caregiver.
Do you know how those village health caregivers get access to health information? I would assume they probably are secondary, they've graduated from secondary school.
Yeah,
Tebello?
most of them have gone up to secondary school. That is why we are designing the care program that will be purposefully done in Lesotho, because some of the English might be challenging for them. And we are already exploring with the director at the Ministry of Health how things can move forward, because we feel like Dr. Tonny is saying, they are right in the community. They are just they just need to be empowered and reassured and be supported accordingly, so that they can be able to be our hands and feet in the communities.
Maybe I could add to that, Erin.
Yep.
To say that you know, we've trained healthcare workers who actually have not been able to read or write. They've had someone who went with them. Sometimes it was like a child or a teenager who could, to write their reports. And they have made incredible healthcare workers in the rural communities. So we even found those who were illiterate, if they had the heart for it and they had someone who could do their recording, they remembered. It was amazing. We've done this across South Africa and many places in Africa. And the project that we worked on in India with the pediatric palliative care, we trained a number of ASHA workers, and they were incredibly good at identifying the children who needed palliative care and then providing the support. But there must be good communication and coordination. They can't do it on their own. It's not fair to them. So they do need some form of supervision, which can be indirect through cell phones. But certainly they're going to be essential. If you want palliative care to reach everyone, they're going to be an essential part of the team.
Any other questions related to cancer care in Lesotho? We will be shortly having Dr. Hassan. I'm not sure who's going to be leading the case, but we'll be hearing from the team. All right, a nice comment from Rosalind about the village health workers, that they're essential to care as they're the ones closest to patients. Of course, many of our patients can't leave home or don't want to regularly be leaving. So that's really good. And they do it in the form of DOT, mostly with patients who don't adhere to their medication. So direct observation therapy, is it? I think, just to ensure that people are taking their medications regularly. And I think, although I don't think we talk that much about DOT and palliative care, it's a very good model to ensure that the relationship between the healthcare worker and the patient is very strong. And I think a level of trust is built when those regular visits happen. We probably call them home visits in palliative care. But I think if you, until more formalized programming is done for palliative care in Lesotho, we can actually use the models that are currently we have access to through some of those NCD programming. I assume this is for tuberculosis or HIV/AIDS. And actually the wonderful thing about palliative care is that you can do palliative care even if you don't have access to higher levels of education in palliative care. Once you begin to believe in the concepts and the ways of providing palliative care, even through some basic introduction courses like the one we've just completed, you can do palliative care during those visits. So yeah, please do if you're visiting patients or if you're seeing patients in an outpatient clinic and it's not your official role to be a palliative care nurse or social worker, if there are things that you can integrate into your practice, we really encourage you to do that. Well, I think we'll shift to the case if there's no further questions. Thank you, Tebello, for the teaching today. Dr. Hassan and Dr. Tonny, would you like me to share my screen? We may have time only for one case because there's a few things we would like to wrap up before the end of the call.
Sure. Okay. You can share, please. Erin?
Would you like me to share? Sorry, I can't hear you.
Yes.
Okay.
Please share from your side. Yeah. Good. Thanks, Erin. Okay. Colleagues and participants, let's see. Okay. So we are going to have a case presentation as neglected cancer care needs. Okay. The next slide, please. So the key questions for this discussion will be, is there a way that the cancer can be diagnosed without specialized investigations, where referrals are next to impossible? How best could we have managed this case and the continuum care, putting the multi-professional and referral system challenges in mind? And taking into account the total care model, how best could we have managed this case? Next slide, please. We're going to look at the patient details now. The patient is a 56 years nurse working overseas, female. Diagnosis was done in 2020 as a adenocarcinoma of pancreas, and 2023 disease progression with metastasis of the gallbladder, and the symptoms were like pain and other distressing symptoms were there. Okay, next slide, please. So current chief complaints when she came to Sankatana clinic, this is the real case, yeah. And physical examination we did, so we did the history. So patient complained of severe abdominal pains, and let me mention that this patient was accompanied by her family members. She was staying alone in abroad in the Arabic country, and she left her family here in Lesotho, but getting sick, and she had to come back to Lesotho to the family. So she complained of severe abdominal pains with vomiting, occasional difficulty in breathing, sleeplessness, and mental confusion. Next slide, please. Okay, so surgical history and medical history in 2020, where she was working in a referral hospital of Saudi Arabia, actually. And she
Dr. Hassan,
Hello.
and there are a few comments about the volume. Your sound
volume.
is a
Okay.
bit faint.
Okay, sorry,
Yeah.
I have to be loud, right? Now, is it okay? The volume now?
It sounds better. I hope
Okay,
they are.
okay. Oh, sorry. So, okay, I'll be loud,
Okay.
more loud. Okay, the reason is that today at the workplace, I had to lecture for the other colleagues from different hospital nurses who were coming from different departments like surgical, TB, HIV. So, okay, anyway, I will be loud. So medical surgical history in 2020, she received chemotherapy and Whipple surgery at her workplace overseas. In 2023, February, she became sick again. And she was admitted in the surgical ward of the referral hospital of Lesotho when she came back, getting sick again, where she was diagnosed with ascites and right chest pleural effusion. Her ascites was drained and discharged from the hospital for follow-up in the Sankatana Cancer Clinic. She was on wheelchair ECG performance scales 4, completely disabled. Next slide, please. Okay, now let's look at the family and social history. She's a nurse by profession, working in a hospital overseas, was married but divorced in 2010. She is a mother of 2 children. Her son is 33 years old and daughter is 28 years of age, staying in Maseru. And she had to leave her job overseas and return to Lesotho, as mentioned. Next slide, please. Okay. Holistic assessment was done if psychosocial and family concerns were noted, like severe abdominal pains, shortness of breath, increased dependency on the wheelchair bound, decreased nutritional intake. Patient is confused and family was distressed also. There was marked incontinence and loss of income, carrying responsibility. Both son and daughter are working and have their own families to take care of. Next slide, please. Okay, so communication part, the patient worried about possibly going to die, leaving behind her children. She was worried about the loss of income and inability to cover her dietary and continence needs, unable to pay a caregiver, family concerned that they are not able to support their mother as much as they would have wanted. Next slide, please. So spiritual concerns, increased amount of stress due to family dynamics, worried about what will happen due to symptoms, concerns about the future. Next slide, please. So recommended goals of care, pain management goal, psychosocial support goal, nutritional goal, mobility goal, and economical goal. Next, please. Recommended goals of care, pain management goal, use of modified release morphine and morphine syrup and lactulose, non-pharmacological therapy for warm massage. Psychosocial support goal, involvement of mental health care team and spiritual chaplaincy service to support patient and the family members. Nutritional goal, involvement of nutritional team in support with porridge, fortified flour, and milk. Mobility goal, involvement of social development and other agencies dealing with persons with disabilities. Economical goal, encouraged her family to support patient financially and also carry out referral for social care input, grants, etc. Next, please. Now, key questions for discussion on this patient. How best can the charitable organization ensure beneficiaries access specialized care with such limited resource settings? And on that question, let us also discuss a little bit how many charitable organizations are there on the ground actually who could assist. Number two, how can the government and charitable organization work together to ensure the beneficiaries have equal benefits to quality healthcare? Number three, is there a way that cancer can be diagnosed without specialized investigations, high fees for tests in the laboratories where referrals are next to impossible? Number four, how best could we have managed this case and continuum care, putting the multi-professional and referral system challenges in mind? Next, please. Okay, so actually, I would request Erin to go back to the last slide, the question slide, and then if the forum wants, we can discuss on those 4 keynote questions, please. I would request the faculties and also the participants if they can suggest, because while dealing with this patient, our team got stuck really like concerning the social and psychological issues, especially the social issues, like you have which you have seen in the previous slide, that she was afraid because she came back from her work. Her children, they stay away from the family. They have their own family and other issues to take care of. But then it seems that the husband left the wife a long time back, 2010. So basically, the patient was alone in the scenario, right? So please, I'm inviting your suggestions on the discussion point, please, through Erin. Yeah.
Yeah, thank you for sharing this case. Do any of our participants have any initial thoughts? There's a comment. Oh, go ahead.
Yes. How best can the charitable organizations ensure beneficiaries access specialized care within such limited resource settings? I think if charitable organizations continue to forge partnerships with all sectors of the society, and empower more people, I'm sure there are a lot more people of goodwill out there who can be of assistance. The more of us enlightened and knowing how we can extend a hand, the better. So continuing to spread the message through whatever available, easy and affordable means, even buying radio programs as Mayor Madikaba has done, Mayor Tebello. We need mobilization. I think it can, in the long run, address number one. It is not the only way. Probably there are other ways, but I believe in mobilization through information dissemination and forging partnerships so that everyone takes part. And then on this one of how can the government and charitable organizations work together to ensure the beneficiaries have equal benefits to quality health care? I think charitable organizations have to find a way of finding champions within government. Within government, there are public servants of goodwill who, once they understand the message, they can use the influence they have within government to make some of these things happen. In many instances, government has good intentions, but it's worrying the speed at which government goes or addresses things. So we need individuals of goodwill who can use whatever influence they have to make things happen. Many times we run to ministers and PSs, and you find actually people who can make things happen are in the lower end of the leadership. So again, it's a matter of passing this through the civil service, identifying interested change agents who can do that. And the other one of diagnosis, I think we should encourage the nation that we should respect the medical experts to always do what they have to do and give appropriate advice. And the way this can be done, partnerships as well in the same vein are needed with traditional healers, because in most parts of the country, even in the urban areas, people still believe very strongly in cultural practices, and a lot of guesswork is done. So if the traditional healers are encouraged to encourage people who come to them to seek professional help, that can take us a long way. And then the other one is issues of how we can speed up early detection. Now I'm talking from the perspective of what I do. We have just had a study here in the city called the spatial urban planning. And within that study, the study talks about how the airstrips within the country should be resuscitated for dissemination of health services, because if say maybe the oncology center at Sankatani is enabled to visit the country through flying, some people can be reached more easily. Even the detection equipment, I don't know what it is called, if it is placed in the hospitals for early detection, that can be helped. But for dissemination of whatever treatments and everything, this aspect should be resuscitated and be used. Thank you. That was a mouthful.
No, thank you. Thanks for your input. I think one of the comments I want to highlight that you mentioned is when we advocate, we need for people to understand what is palliative care and what is the care that can be given to patients. So we might be interacting with a caregiver, or you might be interacting with a government official. And now that we have had some basic training on palliative care, we do need to practice. What are we going to say? What are we going to say to patients or caregivers or a government official to help them better understand what we're trying to get across? And I think that is something that you guys can work on as a team, work on in your workplace, because we need to be able to explain what we do and what we're advocating for. There was a really good comment in the chat from Emily. The whole family needs counseling to help them accept the situation that is prevailing. And I would add also to understand the situation that's currently happening to help them cope. Because there is holistic assessment where the family needs to be identified, it's the social worker's responsibility to help the family access assistance, potentially from charitable organizations as well as the government. And I think this is really important. We know in limited resource settings, it's not a guarantee that these things will be easy to access. But it is really important that when we have the ability, we encourage patients and families to access as much as they can. For sure, I think that's a really good comment. In terms of, I guess, Dr. Ian or even Dr. Tonny, what are your thoughts on, are there ways to diagnose cancer even when you don't have access to good investigation?
I guess that's going to depend very much on the type of cancer. There are some that would be perhaps you'd be able to diagnose without investigations. I'm thinking particularly of skin cancers or skin manifestations of cancers. I guess for other things, you might be able to have a degree of certainty, but whether that will be enough to actually lead to treatment decisions or a decision to follow a palliative care course, it's difficult to say. Perhaps an awareness that any investigation is going to be costly for the family from a financial point of view, it's going to be difficult to achieve, means that if you're going to use investigations, you should do it very judiciously and make sure that you're doing it in a very targeted way and for very good reasons, and you're limiting the number of investigations that you're carrying out in order to be able to achieve your diagnosis and in order to be able to plan your treatment regime.
Yeah. It sounds like currently in Lesotho, there's obviously limited options. Yeah, Dr. Hassan.
And Dr. Tonny, for your opinion. So practically speaking, for all of us here, we know that without biopsy for solid tumors or the bone marrow analysis for the hematological cancer, it's not possible to diagnose actually the cancer. All of us here present in the call today, all of us, we are aware of that. So I'm worried about this question, like, is there any, or does it mean that, is there any way apart from going a lab investigation, like something like a biopsy report to confirm cancer? The answer is no. If all of us, we are aware of. If anybody has any other way to confirm cancer, I don't know. Myself, I don't have any other idea really. So without the confirmation, we cannot actually go ahead with specific therapy for chemoradiation surgery, as we all know. But palliative care, yes, we can provide palliative care from the beginning of the tumor, where the patient is going to the clinic level in the community or the district hospital level. They can provide the palliative care, but money issues versus biopsy report. This is one of the biggest challenge here. There we are stuck. Okay, thank you very much for giving me this opportunity to talk. Okay,
Tebello.
Yeah, I was just saying, probably from the point of us as practitioners, I think we should push a little bit harder, Dr. Hassan, because as you know, you will need those confirmation from the test reports before you actually take action with your team and Dr. Mpuzwe to refer the patients to Bloemfontein. Now that we know on this blanket scale nationwide that people are struggling to pay for 4,000 scan, to pay for 1,800 cytology tests, to pay for 3,000 for colonoscopy, all those expensive tests that are required on one human being. What do we do within our means and our power and our influence and our impact? I think that is why these cancer challenges are all about inclusive of advocacy, because I think that is where we need to really contend in the boardrooms where we are privileged to be part of, to say what can be done to resuscitate the services in the laboratories. Government laboratories, when I was in Lesotho, all the tests were done in the government laboratories, all of them, including the scans and the cytology test, everything. The new birth of the private laboratories came as the market that was available, because there was a care gap when people were now going to Lady Brand and going to Fixbed for the scans and for the blood test and cytology test. That is when the forward thinkers saw the market that was open, and they just hired the small corner in the shopping malls to do those tests in a small room. Small room, when I mean small corner, that's where the machine for those tests are. As you enter to present your paperwork and your sample, the machine to do the test is another corner, because the government laboratories have not been capacitated or upscaled to really meet the challenge. If the machines are broken, I'm saying, we just need to sensitize the budget to be brought into place, or even communicate with the partners like World Health Organization, or even the American embassies, or everywhere, just to make sure the machines are working, or reagents are provided. When I was working in Lesotho, we were receiving reagents almost every Thursday. It was our collection day at the border gate. I was part of those teams. and we were getting those reagents, then they will be distributed to different hospitals. Their laboratories will come to the central laboratory in Queen Elizabeth Hospital to collect their own reagents every Thursday. Thank you.
Dr. Tonny, would you like to go after Tebello?
Yeah, Dr. Hassani, thank you for the presentation. It's very nice. And I just wanted to tell my colleagues and all the participants that whatever Dr. Hassan has presented is not very unique in our communities. Our communities really, we have a lot of patients that are going through difficulties. And there's some of them, it's quite challenging when it comes to the social issues, spiritual and the psychological issues. So, well, obviously, we all know if we come to the same question which are talking about cancer diagnosis, then you definitely need biopsy. You definitely need to make sure that is done. Like what Sister Tebello has said, unfortunately, most of these things, most of the tests are not quite cheap at all, are quite expensive, of course, especially when you have to cost them maybe to Palliative to take it to South Africa and all that. Becomes quite expensive. So the best way is for us to say advocacy, 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 advocacy. Advocacy, it is where it will be the door to everything that we want to do. It is the only door that you can plead with anyone and say, let this one be done. Let us do this way. And without advocacy, we find ourselves that even if you have a little bit of charitable, even if you have a little bit of money yourself, you want to have a patient, but you cannot have everyone. You still get short of some fund to help the patient to go into to diagnose cancer. So advocacy, I think, is the key to everything if we want to go out here understanding exactly what we need to do. Let us, all of us, come together and play our part in our communities, wherever we are, and we increase the advocacy so that we can succeed. All the diagnosis, everything will come into play. I think that is my contribution to this. Thank you.
I think I'll let Dr. Amable say something, but Tony, Dr. Tonny, I think it's really true. We can't expect families to pay for these kinds of tests. It's just not logical. We have to advocate that this becomes part of public health care, universal health coverage. And it's not easy. This kind of work, that kind of work is not easy. We all went to nursing school and medical school so we could do easy work. Easy work that we, at the end of our shift, we feel confident in the work that we've done. Advocacy is really ongoing, and it is the injustices of the world that we're trying to, impact and really change. And I think you're right. We will not change the world in one day. We continue to do the things that are right in front of us, but we always advocate. I love what you mentioned. Dr. Amable, would you like to say something?
Yes,
we have a
yes.
few more minutes.
Erin, thank you very much. I've appreciated everything you've been saying, actually, but I would like to remind everyone on one thing. Whatever we do, most of the time we focus on diagnosis, or diagnostic things, but remember that every disease starts by history. It starts by the onset, and then it becomes either advanced or metastatic, most of the cancers. So what I was about to remind is that we need to do a thorough and complete history before we even think on diagnosis, because I've seen that many cancers, mainly in low and middle income countries, they present in advanced stages or even in metastatic stages. So we think we need first to increase the awareness in our communities, and then later on try to do something that may increase the awareness. And then after getting the true history and the thorough one, then we can think on those diagnostics, of course, after a physical exam. From there, we can at least help people, because we will be getting cancers in early stages, and from there, most of them can be cured. And from there, at least you can be having a healthy and a greater outcome. So we may do that and then do advocacy for further investigations, but at least we can be having the cancers that have been diagnosed early as early we can. So thank you very much.
Thank you. I think it's also a really good reminder to go back to our primary healthcare skills of assessment and really understanding the patient. I think it's a really good point.
So I have a question, please, with your permission, Erin. Yeah.
Yeah, put your microphone closer.
Oh, sorry, sorry. Thanks for the reminder. Okay.
That's okay.
So I want to follow like the colleagues I respect, or with all due respect. So suppose a suspected CA prostate patient, you have got a PSA of an elderly male of 2,282. Yes, you are understanding that the PSA says that there is like 80-90% possibility of prostate cancer. Even then you have to do a two-cut biopsy and send it to the lab, right? So what you do as a clinician, do you wait for like how long do you wait? Those are the like questions can be discussed really. The best part is advocacy prior, actually, like Tonny said, and other colleagues you were alluding. So advocacy should be started like before we see like it should be simultaneously like brushed up while we are focusing on the clinical and pharmacological and social, spiritual, but somebody or a group of people should be like totally engaged in advocacy. Then we might, as a team, we can achieve it. Thank you very much.
Dr. Hassan, do you guys do like tumor board discussions, or I would assume certain things would need to be in place, especially in limited resource settings where the frontline clinician would have confidence to know what to do.
Yeah, what is happening here, like we discussed to build up a like tumor board discussion, but what we are doing at the moment inside the clinic and outside the clinic, two discussions happen. We have Queen Mammoth Hospital where we admit our patient. We have got few beds there in a referral hospital. There, the surgeons, medical department, radiology. We have I think 2 days discussion, basically mostly on surgical and gynecological patients, discussion with our oncologist and palliative care. I also attend the patients there, so with my other colleagues, and we have our own interdisciplinary team inside the Sankatana. The Wednesdays we sit together and we discuss selected patients where some of our colleagues are, me, myself, or others were stuck. We discuss Dr. Omtutse and other colleagues. We sit on that patient and discuss the cases. Thank you.
Okay, so I think that's really good. I think even in situations where you have frontline clinicians with not a large team like that, telemedicine can also help. So getting some of those systems in place may be good. Dr. George?
So thanks very much. I mean, I've been following the discussion with great interest because I do sympathise. I think without access to diagnostic tests, it must be incredibly difficult and extremely frustrating for clinicians. And I'm picking up a theme that Ian raised and Dr. Tonny and you too, Dr. Hassan and Erin. I'm grateful to go to reminding us that, you know, we are clinicians and we are trained to use the clinical skills of taking history, examining our patients, making some sort of diagnostic impression, or on the basis of the history and the examination, we should be able to make some sort of diagnostic impression, which we would then look to tests to confirm or refute. And that, Erin's absolutely right, this basic approach to diagnosis is incredibly important. However, my question is that, and you touched on this around the issue of tumour boards, Erin, I would be very interested to know if there are pathways that clinicians follow on the basis of particular conditions that present. So for instance, what are the commonest causes of cancer in Lesotho? What are the common causes of death? And can you link sets of symptoms that would support and enable clinicians who are seeing patients for the first time to pick up, we call them red flags in symptoms here. And, you know, on the basis of a set of red flag symptoms, it would lead you to think that the situation is much more serious than it might have initially been thought to be. So I'm just interested to know whether stepping back a little bit and looking at the epidemiology, if you like, might help clinicians who are faced with these difficult decisions about what is actually wrong with the patient.
I wonder if maybe Joan would also like to comment on this a little bit, but I wonder if they don't even have, I don't know, but I wonder if there is just lack of data in general. If they don't know what a primary diagnosis is, they may not also have a cause of death. It would be quite vague, I would assume. I don't know.
And I
Joan?
think Tebello probably and Dr. Hassan would know better what the epidemiology is in Lesotho. I mean, there is some details, but you haven't got cancer registers, I don't think.
Dr. Hassan, you're
No,
muted.
We did not have any data as it was scattered in the country, lost to follow up so many patients.
Yeah.
So what we did from the very first day when we started the clinic in Old Queen 2 Hospital in 2000.
Can you put your microphone closer, Dr. Hassan?
Okay,
Sorry.
yes, yes. Do you hear me now?
Yeah,
Yes.
yeah, sorry.
Yeah. So what we did, like the patients were scattered before we started the clinic. So when we started the clinic, from the very first day, we started build up each patient have an unique number and a file where there's a clerking chart and a biopsy report confirming the cancer. And then both in hard copy and soft copies. BMSF, Bristol Myers Squibb supported us with the desktop and staff, the receptionist, and who at the end of the everyday consultation collect the files from us. Like in the morning, they give the files, and in the afternoon, they collect it and put it in those data, even the geographical, like the address, passport number, age, where the area she is coming from, phone number, contact numbers, everything is in the data. So we have since last 2020, 21, 22, 23, 4 years, we have all the patients who came across Sinkatana Cancer Clinic. The data is in the soft copy and also in the hard copy, and it's still going on. That's the update from our side. Yeah. And the cause of death, as one of our colleagues mentioned, it can be like comorbidities or the cancer itself. Those who were late diagnosed, like lymphomas, non-Hodgkin's lymphomas, late to be diagnosed and late to attend at Sinkatana from the very far district. So there were challenges. Yeah, it's true. But other patients like who were treated like breast cancer, we are doing breast cancer chemo here in Lesotho since last year. Over last 1 year, we are doing the solid tumor breast cancer chemo here in the Sinkatana. We are not referring them to Bloemfontein. Only for radiation for breast cancer, we refer them. The other cancer we refer. So in short speaking, that the breast cancer responds well, and their survival is, I don't think it's frustrating. No, it's good. We are providing tamoxifen or arimidex for follow-up patients. Their survival is many years, as the history says. Okay, so it depends on the diagnosis, like the death. So we also put a record of death. It is available in the clinic. So that's my response. Thank you very much for asking this question.
Does anybody have a final comment? We are going to be wrapping up the session, and I know that we've probably are all feeling a bit heavy right now, so I would love to have someone, Christina's not here, to be with us tonight, but
Harriet will help you.
Harriet, okay, Harriet.
Is she still with us? Oh, she's there.
What are you asking me to do? Sorry.
Can you lead us through a 2-minute mindfulness session? Because I feel like we all have the weight of the burdens right now on our shoulders. We're grateful that the participants are still with us. We've had about 50 on the call tonight, which is great. But just before we end the call for today and end the course, do you mind, Harriet, bringing us back to focus?
Really hadn't prepared anything for mindfulness, but I just really want to bring us back. Maybe what we can really just bring us back to is a focus on the fact that this is heavy stuff. That's the nature of the work. But in it all, in the middle of the heaviness, in the middle of the difficulties, we still have to remember that we are just human beings. And as human beings, we also have our emotions, we also have our experiences, we also have things that will surface because of stuff that we are thinking about. But let's remember to look after ourselves. Let's remember the five ways to well-being, which we spoke about a few weeks ago. And even right now, as we are closing off, if you can just take yourself in your mind to something that you enjoy doing, and just take yourself there just for 2 seconds. I enjoy being by the seaside. Anywhere where there is water, that is my soothing. That's where I go to. That's where I go to in my mind when I'm getting overwhelmed. That's the sounds that I play, the sounds of the water flowing, the sounds of waterfalls, the sound of that. So even if I can't get to the sea, I can play something on my phone, on Google, that has got a waterfall, and that will calm me down. So if you can find something that helps you, just something, particularly in nature, because nature is intended to calm us down. It is intended to give us an outlet out of the things that we've taken in that we shouldn't have. So I'll say 2 seconds. Everybody, for 2 seconds, go to your happy place.
Oh.
Thank you, Harriet. Thank you. Let us finish today with sharing in the chat. So we don't have a ton of time and we're already over time, but we want you to leave this session feeling empowered. So we'll do that silly game that we do on Zoom where you put something in the chat, and when I say 3, 2, 1, everyone push enter so we can see a waterfall of comments coming through. So I would like you to put in what you're hoping to do in the next 1 or 2 weeks to integrate palliative care into your work. So what you're planning to do in the next 1 to 2 weeks, so before the end of October, to better integrate palliative care or holistic care or assessment of total pain into your work. And we'll ask everyone if they can put their videos on. We would love to see you. I'll take a quick screenshot when we have quite a few of the participants on the call. So think of what you want to write. I'll give everyone 1 minute to write what they're hoping to do in the next 1 to 2 weeks to integrate palliative care into their work. And when I say, hey, Dr. Hassan, when I say 3, 2, 1, push enter. Hey, Tebello, wait. Okay. All right, 3, 2, put your videos on, 1. All right. We've got some things coming in. I feel like I need to start reading these then. Okay, compassionate care plan, advocacy, Tebello, and all the people from Starlight, please hear this. This is what everyone is planning to do. Step down training, empathy. I'm going to Lesotho, apparently, Dr. Ian, which is great. Giving bereavement support to a friend. Okay, Jillian, thank you. Counseling, including in their elderly nurses course and HIV AIDS. Perfect. Integrating palliative care training into training you're already doing, which is wonderful. Advocacy, educating colleagues, information sharing, really, really important. Teamwork. Yeah, we always need to do teamwork. Advocating for patients to receive more pain medication, as it's always a struggle for sure. storytelling is a good way to advocate for these patients. Joan has some really good contacts. Lucinda at Palchase is one of our great storytellers, and if anybody would like to reach out, I'm sure Joan can connect you with her. Engaging with colleagues, advocating for morphine, strengthening the referral system. Great. You guys have a very busy 2 weeks ahead. Well, why doesn't everyone put their video on, Tebello? I'm going to give you the final microphone, unless there's anyone else that wants it. And Tebello, I'm going to take a few screenshots here, but over to you, Tebello, and you can end the session.
I don't know. You can give them if there's any one of our participants who want to say a word before I say. That's fine.
Any participants would like to comment? This is our last week. This is your graduation. This is as good as it's going to get. A virtual graduation.
I think Tebello and Erin should all have a round of applause, because I think they've done an amazing job.
Thanks, everyone.
Yeah. Thank you, everyone. Thank you, Dr. Ian, and thank you. I have got no words except thank you. And I thank this moment in time that has been brought to the fore in this manner and shape. And I just want to encourage each one of us in our personal journeys, in our familial journeys, in our professional journeys, that just keep on keeping on, because there is energy in hoping. As individuals, as human beings, we are born with an internal wiring of being hoping hopes. If it wasn't the persistence and believing even in the unbelievable, I don't think we would have come to this stage. And it is not been by power or by might. It's been just by the guidance and trusting that the journey ahead, whoever designed it in my mind, has got the better knowledge. And the better knowledge has been that you have been part of that journey in different ways. So I just want to appreciate all of you, even our colleagues that have not been part of these trainings. Some are just working so hard behind the scenes, but I'm just appreciating that this moment has really shown that the humanity in all of us is still alive and existing, and it will push through the barriers, the detours, the obstacles, the opposition. If you mean opposition, Starlight knows it very well. That's why one of our values had to be patience. Patience in the timing and into the process. Because if it wasn't that patience, one could have really put the tools down long time ago. But I'm always been reminded that the name that was given to me in the dead of the night to call our daughter Patience as our firstborn, I didn't know it was meant to carry me through any journey, whether personal or professional. So I'm just saying, let's be encouraged, don't give up hope. As you try with a full energy and revived compassion, trying to steer change within your workplace and practices, even if you see opposition or discouragement, just allow the water to run over it and get over the other side and become a bridge that the services can change for the betterment of our patients and their families, that the services can be coordinated and collaborated so that there's no distress and delay in giving our patient services. We need the clinical social workers. I don't know how many times to say it. We need the chaplaincy services in our hospitals and clinic. We need to ensure that we are on speed in escalating the needs of these patients so that if they need assistive devices, if they need social grants, whether short term, medium term, or long term, we need to really ensure that we assess the pain properly. Dr. Hassan, we will still do our own homework. We will meet again in Lesotho with all your teams. We needed to escalate the use of pain assessment tools, because it is only when we assess this pain properly that we will know that this Tramadol is not enough, this paracetamol is not enough, this codeine is not enough. Then we need more. And when there's more orders and requests to the pharmacy, the pharmacist will escalate it to the senior pharmacist to say, there's more requests for morphine, but we only have 2 boxes in the in the cupboard, and it's not enough for this. The 30 patients just only this week that needed morphine. That is when advocacy starts. And then there's the driving force behind, can we sit around the table and explore what is the best option to get more access to these stronger painkillers and essential medications. So I can just say thank you, everyone. Listen to your inner voice of what difference can you make in your own way. Medina has shared with us in her own way. She said, I will design the home for Starlight. And that is what she did. And she is part of the movement for change for me and you and for everyone. Starlight is not for one generation, it's for generations to follow. So let us make this palliative care knowledge a tool that will drive the change and impact the quality of life we provide for each one of our people. And who knows, that people might be anybody closer to our inner cycle, God forbid. Thank you very much, Erin, for all the opportunity. Thank you for our partners. Thank you for our colleagues in Lesotho, and thank you for all your families and everybody in your social system, because it has been a commitment by families that we came on this call each week. Thank you.
When is the next call?
We'll go through, let's do our smile or thumbs up or I don't know, amen. Everyone, I'm gonna take a screenshot. Tebello, here we go. So are you guys ready? Okay, 3, 2, 1, say cheese.
Cheese.
Hold it, wait. 1, 2, 3, one more. We have too many people. I have to do two screenshots. Last one. Okay, ready? 1, 2, 3, smile. Put your videos on. Nice. Great work. So, shall I stop? I'm going to stop the recording now, Tebello, just for a minute.